We are now live on YouTube. We are good to go. Good evening all. I am Armugam Balasubramanian from Mindray India ultrasound team. Mindray proudly welcomes you all again for Fetal Radiology Samrakshan webinar with another interesting topic, fetal growth restriction. We welcome Dr. Rijo Matthew, Dr. Lalit Sharma, Dr. Bhavagran, IRIA Krest Kochi, and all the delegates. Let's begin this session with a tech talk from an industry expert. Ms. Viraj Solanki from senior member from Mindray India ultrasound team will present us smart plane CNS technology and artificial intelligence based 3D 4D technology to us. Over to you, Viraj. Thank you.
Thank you, Arumugam. Good evening, everyone. I'm Viraj Solanki, Application Manager in Mindray Medical India, handling ultrasound division. I welcome you all in this web platform of IRIA Kochi and Krest Kochi powered by Mindray. We'll quickly have a look at the latest technology, the Mindray's unique, amazing technology that Mindray has. So we are going to talk about the smart plane CNS. So before that, let me talk about the clinical value of CNS screening. So first of all, fetal central nervous system malformations are one of the most common congenital abnormality and occurring in about 1% of all the births. Ultrasound has been one of the main modality to diagnose the fetal CNS nearly about 30 years. According to the issued guidelines, a basic examination in fetal CNS major planes inspection, that is transcerebellum plane, transventricular plane, transthalamic plane, and the mid-sagittal plane. Now, there is a clinical difficulty to screen mid-sagittal plane in 2D. And why it is so? Because of the first of all fetal position, and second is definitely the scanning skill dependency. So this is how we face a difficulty in 2D screening of the mid-sagittal plane. And here we have a quick and easy to handle tool to get basic standard planes in CNS examination, which will be much helpful for the clinic diagnosis. So these are some of the glimpses of the smart plane CNS feature and how we can get amazing images out of this, this latest technology that we have. So this is all about smart plane CNS. Let's have a look on the principle of this. So basically, it's completely based on the artificial intelligence, which is based greatly on the number of normal and the disease cases over 5,000 plus cases. So precise plane recognition based on the advanced algorithm, it detects the central nervous system planes accurately based on calculating the appropriate parameters. So this is about the principle. It is completely the artificial intelligence based technology. And here we are going to see how it works. So first of all, it is a volume plane. You need a volume data set. So you need a volume probe for this, convex volume probe. Once you have the acquisition of the 3D fetal head data set of the BPD view, all you need to do is just press one touch on the touch panel, that is Smart Plane CNS button, and you get all the 4 planes, that is automatically, that is transcerebellum plane, transventricular plane, mid-sagittal plane, and the transventricular plane. So this is how you get all the 4 planes automatically, and just by one more touch on the touch panel, you get all the 6 measurements automatically. That is the BPD, OFD, HC, TCD, cisterna magna, and the lateral ventricular width. So all you need to do is just acquisition of 3D plane, and machine gives you all the 4 planes automatically. Again, the best part is you need not to worry about the annotation as well. Machine just by one touch gives you all the annotations like the orientation part, the up, down, anterior, posterior, lateral, the right, left, everything, as well as it gives you the annotation of the CNS structures automatically. So this is very beautiful feature and very unique in Mindray. So what are the benefits? Of course, it's an intelligent tool which minimizes your scanning time, improves the clinical efficiency, and reduces the operator's dependency. The second is it improves the MSP, the mid-sagittal plane acquiring rate, and enhances the diagnostic confidence of the CNS study. And of course, it is very accurate, and the accuracy of the CNS anatomy will increase dramatically. So here we are going to talk about the Professor Felipe Genti. He needs no introduction in the world of ultrasound, and what he has to say about the smart plane CNS is he has used this system in one of the forum, and he said that before that, before the smart plane functions, we need to do multiple scannings to get the standard views of the fetal brain, and it took a lot of time and labor. And now we get what we want in just 1 second with just few key presses. So this is about the latest, unique, and amazing technology that Mindray has, the Smart Plane CNS. So with this, I end my topic and I hand over to Dr. Rijo. Thank you so much.
Thank you, Raj, for your insightful session. Over to you, Dr. Rijo.
Thank you, Viraj, and thank you, Arumugam. So once again, welcome all the participants to the Krest Kochi. This is the 12th webinar organized by Krest Kochi, IRIA Kochi. And we have organized webinars on breast imaging, MSK imaging, and for the PG webinars for the postgraduates to present their cases, and also a series on fetal radiology at Samrakshan. Today we have we are starting a mini series of 4 talks. The 2 talks will be today, and the next one will be on 9th, powered again by Mindray at 7 p.m. on 9th. This is a mini series on fetal growth restriction. I am really happy to note that the discussion and discourse on fetal imaging in this country is now focused on fetal growth restriction. The priorities that is due for fetal growth restriction and preeclampsia is being given by the larger by all the stakeholders in the larger context of maternal, fetal, and neonatal medicine. We can see a lot of talks on fetal growth restriction, many webinars being organized by different groups and being given by masters and ultra masters. So I'm very happy on that note. And today, as you all know, this is a series based on the Samrakshan project of Indian Radiological and Imaging Association. Samrakshan is a project that aims to reduce the perinatal mortality in India. We have been telling a number of times that the perinatal mortality in India is quite high. We contribute to 25% of perinatal deaths in the world. And perinatal deaths means fetal deaths beyond 28 weeks and early neonatal deaths up to 1 week. So that period, the major causes of fetal growth, major causes of perinatal deaths are preeclampsia, preterm, prematurity, and fetal growth restriction. So it's high time that we need to focus on this. And that is why Samrakshan has focused on the first trimester screening for preeclampsia and fetal growth restriction, And the second focus of Samrakshan is on the third trimester screening for fetal growth restriction and its proper management. So in this series, we have two very good speakers, two experts, two people who have got different background in their work. But during my Samrakshan journey last year, I have come across many such people who are really good and experts in their field. They are doing dedicated and committed work in the rural areas, in the talukas, in the tier 2 cities and in the mini metros of India. So the second talk will be given by Dr. Bauharin Rajlingam. He is the CEO and Managing Director and the Chief Radiologist at Magnum Diagnostic Center, Trichy, which is a multimodality center, and he does a very good number of cases. And I've been traveling with him in his for the Samrakshan CMEs all over the country. We have been focusing on the main states in India where the perinatal mortality is quite high. That is Uttar Pradesh, Madhya Pradesh, Rajasthan, Chhattisgarh, and Odisha. And he is the national academic lead for Samrakshan, and his talks are mesmerizing. And you will hear that as the second one. But before that, I have to introduce the first speaker is Dr. Lalit Kishore Sharma. He's a senior radiologist who has been working 40 years in the rural areas of Guna district in Madhya Pradesh. And maybe last year during the indoor CME of Samrakshan, he was introduced to me by Dr. Hemant Patel, the president of Indian Radiological and Imaging Association last year. And he was introduced, and more and more about him I heard from the state IRA office bearers of Madhya Pradesh, Dr. Sodani sir, Dr. Pushparaj Batele, etc. And then I got introduced to Dr. Lalit Sharma, and we started seriously analyzing his work. So what we realized was for the last 10 years, maybe when we became the president of Rotary Club in Guna, he initiated a project along with the district administration, mother and child department, and the district hospital there, covering 38 Anganwadi centers, approximately covering 60,000 people, and started a social radiology project that is one of its kind and unique, where mothers' antenatal care has been taken care of with proper imaging. And what he did was he collected and documented everything. So he had a unique ID for all these patients. He properly documented all these things and kept the record of all the babies till 5 years, because it's associated with the Anganwadi workers. The Anganwadi workers and the healthcare workers also was part of the team. And we just analyzed this work, and it was published by Dr. Lalit Sharma's work was published in Indian Journal of Radiology and Imaging in the last edition, the April edition, on the studies on the discordant LMP and in 14,000 pregnancies, because that is a study that he will be highlighting in his talk, the importance of corrected EDD, in importance of dating in the pregnancy scans, because that is highly detrimental if you are not looking at it from the fetal growth restriction, fetal deaths, and the perinatal mortality rates in India. So from that particular study, we realized that nearly 50% in India, especially in the rural India, doesn't know their LMP, or their LMP wise, if you calculate the gestational, if expected date of delivery, that is going to be either underestimation or overestimation. So it is high time that we need to address this topic. That is why we had to break this loop. That is why wrong dates can become a cause of perinatal mortality in India. We have to break this loop. That will be the first topic that will be handled by Dr. Lalit Kishore Sharma. Over to you, sir. Dr. Lalit, sir, you may start your presentation.
Dr. Lalit,
okay.
Sir, can you please share your screen, sir?
Sir.
Share your screen, sir, please.
Am I audible now?
Sir, make it, yeah, slideshow.
Okay.
Yeah, you're audible.
Okay. Very good evening, each and everyone. And thanks, Dr. Rejo, for so kind words. I extend my thanks to the organizer of this CME, Krest Kochi, IRIA Samrakshan, and sponsor of this team, Mindray.
Sir, can you be a little more louder?
We all know that we are living in the fear of corona nowadays, which has killed almost about 2.5 lakh people all over the world and about 1,700 people in India. And very soon we will be habitual of living in this, under this, and we can have a vaccine. But we have not noticed that since many years, there is a cause of death for our unborn children and many mothers, and that is because of perinatal mortality in India. You know, one very important thing I want to highlight, that though we have got a vaccine for this already with us in the form of Doppler, but no one is using these. Our main aim under the Samrakshan to highlight this thing, that if we correct this wrong dates, which is the main culprit, which is leading to the adverse perinatal outcomes. And one International Institute of Population Science, the National Family Health Survey, NFHS 4, has highlighted this, that high perinatal mortality in India may be caused by the inaccurate dating of pregnancy, resulting from suboptimal uptake of the antenatal care and ultrasound services during the pregnancy. And you know, India has very high perinatal mortality, which is 36 per 1,000 birth, and neonatal mortality 30 per 1,000 birth. So what we can do to break the loop for this, we have to assess the accurate gestational age. Accurate gestational age is the fundamental requirement for both low and high risk pregnancy. Uncertain gestational age results in the low birth weight, spontaneous preterm, postterm delivery, which are independent of maternal characteristics. We have about 3.5 million premature births every year in India. And according to the Journal of Perinatology, published in December 16, they say preterm birth due to any cause will cause 43.7% of the fetal death, perinatal deaths. Kramer et al. Assessed over 11,000 pregnant women who underwent early ultrasound examination, and 1/4 of those infants who would be classified as premature and 1/8 of all infants who would be classified as postterm by menstrual history alone would be misdiagnosed. So, why we need accurate dating? Because for the timing of appropriate ANC care, for scheduling and interpretation of the test, for determining growth pattern, whether they are appropriate, they are less for gestational age or more. And for interventional purpose, whether we have to do CBS, which can be done only after 11 weeks, or amniocentesis, which can be done after 16 weeks, or MTP up to 24 weeks of pregnancy. Or if we have to follow the Samrakshan protocol for the growth disorder, preterm, postterm births, and other maternal related comorbidities. Another condition which is unique to our India is lactation amenorrhea, because many women, they go every year in the pregnancy, and in the PCOS patient, we have to know the exact timing of gestational age. So what are the common indication of early ultrasound examination? Because in our country, we cannot ask every mother to come to us, but the symptom related mostly to them, they are amenorrhea, when patient doesn't know that she is pregnant, or there is unknown menstrual dates, or there is vaginal bleeding, when there is subjective feeling of pregnancy, or uterus on examination is greater or smaller than dates on the clinical examination, or when the pregnancy test has become positive or there are increased level of HCG levels, or when a treating physician has asked for the knuckle transparency measurement. So what are the method of assessment of gestational age? Traditionally, LMP has been used as a reference point with a predicted delivery date 280 days later, or by the Naegele's rule by subtracting 3 months and adding 7 days to the first day of last menstrual cycle. But there are inherent problems in assessing the gestational age by the LMP. What are those? Many women do not have regular menstrual cycle. There is a varying length of the follicular phase. Ovulation occurs within a wide range of 8 to 31 days. Ovulation may occur at unusual time or may not happen in that particular cycle, even in most regular cycles, resulting in the uncertain dating. Many women do not routinely document or remember their LMP. Campbell et al. Demonstrated that out of more than 4,000 pregnant women, 45% were not certain about their LMP as a result of poor recall, irregular cycles, bleeding and early pregnancy, or oral contraceptive use within 2 months of conception. In central India, where I live, most of the time when I ask about the LMP, the mother says for her the last day of menstrual cycle is the first day of menstrual cycle is the last day when the menses stop, and that varies between 3 to 7 days, which adds in the inaccuracy further. And our own data, which Dr. Rizzo was referring, which is recently published on 30th March in the Indian Journal of Radiology, showed out of 14,701 screened pregnant women, 4,683, that is 32, could not recall LMP. Of remaining 10,018 who recalled LMP, EDD by USG matched in 7,035 only, that is the 70%, while in 2,983, that is 30% of these, did not match EDD by USG. So overall, if you see, about 52% of the women, the EDD by LMP or it does not match or they don't know. So we have to know the exact gestational age. Out of these 2,983, where both the EDD by LMP and USG did not match, about 2,611, that is 87.43, would have been classified as growth restricted fetus, and 372, that is 12.53, as postterm by if we date by LMP alone. So misclassification of infant as term by LMP assigned EDD, when ultrasound assigned EDD or best estimate EDD indicate preterm, resulted in the high risk of infant mortality. So what are the method of dating of pregnancy other than LMP? The ultrasound derived best estimate gestational age is used for that. Dating pregnancy by early ultrasound examination at 8 to 14 weeks by the CRL method is the most reliable as per the ISRO's guideline. Once the CRL exceeds 84 millimeter, SC should be used for the pregnancy dating, or SC with or without femur length be used from the mid-trimester if a first trimester scan is not available and the menstrual history is unreliable. Once EDD is established accurately in early scan, we have to remember that subsequent scan should not be used to recalculate the gestational age. First trimester CRL method is of utmost importance for dating the pregnancy and future planning. The sagittal view of the fetus in neutral position, the horizontal on the screen should be taken. Caliper placed on the crown, that is skin above parietal bone, and rump, skin inferior to the tip of sacrum, should be taken. And we have to use appropriate depth and magnification. Axis should be 90 degrees to the ultrasound beam and must be less than 30 degrees to minimize the mistakes of measurement. And after that, document the most correct measurement taken so. And these are the pictures. Here the 90-degree horizontal. Here the angle is 10 degree. As the angle increases, the inaccuracy increases. This is the picture which is most appropriate using the correct caliper placement, correct magnification and correct depth. Here fetus is not scanned in a correct depth. Here magnification is very less. Here fetus is in the flexion and here it is in the extension. They all add inaccuracy in the measurements. So we have to be very precise while taking the measurement and must use the correct method. And what are the criteria in the second trimester? According to ISO's guideline, we should take SC plane which is symmetrical, should show thalami and CSP, but cerebellum must not be visible. Head must occupy more than half of the total image. Caliper and dotted ellipse should be placed correctly. And while taking abdominal plane, it should also be symmetrical, should show stomach and portal sinus, but kidney must not be visible. And abdomen must occupy more than half of the total image. Caliper and dotted ellipse must be placed correctly. When taking the femoral plane, both ends of the bone should be clearly visible. Angle should be 45 degrees to the horizontal plane and femur must occupy more than half of the total image. And then caliper must be placed correctly. These are the pictures, how we should take the SC, how the abdominal circumference and how the femur. And in the third trimester, it is not good for assigning gestational age. If we assign, we should be writing it that it is not correctly dated. If matches LMP, it is good. Otherwise, interval growth scan are better. In the recent ISO guideline, given the error inherent in expected fetal weight, the time interval between the scan should typically be at least 3 weeks to minimize false positive rates for the detection of fetal growth disorders. Other parameter other than the biometry, sometimes we can use the cerebellum, interorbital distance, kidney length, or ossification of the long bone. But after taking the biometric measurement, there are important tasks before redating. While doing dating scan, date the pregnancy as per guideline I have discussed and clearly document it in your report whether you have assigned EDD by LMP or by USG. Always ask for early scan report to the mother. Make mother aware about the difference of these datings. Always stress the importance of carrying previous scan report with her on subsequent exams. Understand the previous USG report and spend some time in reading report from the other radiologist. Once, very important thing, once redated, don't change the EDD in subsequent visits. Rather see it as a growth discrepancy. Then how to redate? What is the difference which makes her to change the dates? Between 6 to 9 weeks, if the difference is more than 3 days, with the ovulation study or embryo transfer, if the difference is more than 3 days, between 9 to 14 weeks, the difference more than 5 to 7 days, in the earlier weeks, difference of 5 days and later 7 days. Between 14 to 16 weeks, the difference is more than 7 days. Between 16 to 20 weeks, the difference more than 10 days. And between 22 to 28 weeks, the difference more than 14 days. And after 28 weeks, the difference is more than 21. That's why the interval growth scan are better. Accurate dating also helps us in resolving the maternal characteristic related complication like we are working in the Samrakshan for that. Hypertensive disorder of pregnancy, preeclampsia, eclampsia, which accounts for about 22% of perinatal complications. You know, small for gestational age fetus prevalence in India is 36% with highest neonatal death, that is 202 per 1,000 births. The prevalence of intrauterine growth restriction is reported at 54%. And to highlight, about 64% of the death results after 37 completed weeks. So we must know what is the exact gestational age and what is the EDD assigned like this to take the proper management decision. IRA Samrakshan protocol has come forward since June 19 to tackle these problems. And what are those? First trimester predictive scan during the NT-NV scan, and third trimester Doppler, which has a definitive preventive and management role in cases of SGR, hypertensive disorder, preeclampsia, and eclampsia. Dr. Bhavran will be highlighting these changes. And it also addresses the growth scan assessment. And as per the SEO guideline, should be described as AGA, SGA, LGA, and FGR fetus with growth in the centile based on the dating EDD in the subsequent exam. The term early onset detected before 32-week gestation and late onset detected after 32 weeks of gestation be added in case of SGR. Calculate the growth and manage accordingly to the Barcelona calculator guidelines. Now, here comes few examples to highlight our method and how the LMP date is not accurate. I examined a patient on 24th of April. Her LMP was 30th 11/19. So period of amenorrhea will be 20 weeks, 6 days, and LMP based on it is the 5 September. But she got married on 31st January. And CRL on examination, CRL was 38.5 millimeter, which correspond to 10 week, 5 days. So I have assigned EDD now by ultrasound, and as per the corrected EDD, have advised for the NT-NV scan, predictive first trimester scan, for TIFA and Doppler later on to judge the proper growth and take the proper decisions. Another patient came on 30th April now with bleeding PV, little spotting. LMP was 8th March. So period of amenorrhea will be 7 weeks, 4 days. And on examination, the CRL was 3.1 millimeter with cardiac activity, which came to the 5 weeks, 6 days. Because the difference is more than 3 days, and that shows there is a 12-day discrepancy. If this mother comes in the second trimester, and after that discrepancy becomes 14 days, it will add to prematurity. It is very important to assign EDD as early as possible if the patient comes. Here is another example. One lady came with whose LMP was not known, and she was 38-year-old lady. I examined her on the 6th of October, dating done, because of she was having feeling of pregnancy, and gestational age was 6 weeks, 5 days. So I asked her, as she was elderly lady, to come for the NT scan. I examined her, her NT-NV were normal, but limbs were very small. When she came TIFA, I observed that she was having a short dwarfism and the thorax was small. So we gave option for terminating the pregnancy and they adopted. This is the picture of the fetus. If we have not examined her, we cannot advise her for the timing, appropriate time of the MTP. This is very, very important because about 32% of cases, the women are not knowing their LMP dates. Another example, how the Samrakshan protocol and early dating helps us. On dating scan, gestational age was smaller than LMP dates. So I assigned the EDD by USG. If the important take message from this, if gestational age alone, hence the EDD not corrected, it will result in the wrong decision of delivering a baby prematurely on the basis of grade 3 FGR changes in this fetus, which has all the right to live more intrauterine life. This is how I proceeded for it. a lady came on 7th of May with LMP of 8 January and period of amenorrhea was 17 weeks 0 days. But on examination, the CRL was 55.1 millimeter corresponding to 12 week 1 day. So I reassigned her EDD and gestational age and did her predictive scan as per Samrakshan protocol. She was on higher risk for the preterm preeclampsia because of uterine artery PI were more than 95 centile. Then she came again on 28th of the September, where if we would have not corrected her EDD, the LMP period of amenorrhea will be 37 weeks 4 days. And on Doppler, she was having grade 1 changes of FGR. So now as per the protocol, the management will be labor induction because it has achieved the growth complete 37 weeks. So to avoid the perinatal complication, we will advise this. But as we redated the pregnancy and her actual period of amenorrhea is 32 weeks 5 days, and management now has deferred. It is now the weekly follow-up till we get abnormal changes or 37 weeks are completed. Again, she came on 7th of October and still she was having grade 1 FGR changes. So again kept for the weekly follow-up. On the 15th of October when she came, the actual period was 35 weeks 1 day. We have crossed the 34 weeks and there was absent and diastolic velocity in umbilical with the ductus venosus PI going above the 95 centile. So it became grade 3 FGR. Now we have recommended the LSCS and the delivery. On 17th of October, 1900 gram live baby was born and is still doing well. This is the example. If we have not redated the pregnancy, this baby might have lost the child time to live intrauterine life, and it would have been born prematurely with lesser weight and might succumb to in the perinatal period. These are the Doppler changes of this fit. Same. Another example, gestational age as per LMP dates on the dating scan. EDD was assigned by LMP. Adherence to the dating scan in the subsequent examination helped us in the understanding the follow-up growth scan and take proper management decision. This is about the LGA fetus. A 36-year primary, non-diabetic, non-hypertensive came on 24th of September with LMP of 27 June. Period of amenorrhea was 12 weeks 5 days corresponding to the LMP dates. So we assigned the EDD by LMP. On Doppler, at 34 weeks, when she came, there was mild polyhydramnios and expected fetal weight exceeded 90 centile. So it is a larger for gestational age fetus and with polyhydramnios. Previously, she was non-diabetic, but I asked to exclude the GDM and she turned out to be GDM patient. Again, on 25th of February, there was though little polyhydramnios was there, but the expected fetal weight reduced to 83 centile, and now the uterine artery PI went out the 95 centile. So Doppler changes has come. Again, after scanning after a week, the liquor reduced to 6 centimeter, CPR also became abnormal, and the expected fetal weight came to 43 centile only. So as this already gained the weight of 2700 gram and diabetic fetus may succumb anytime, we advise for the LSCS. The baby was delivered on 4th of March. Surprisingly, there was no liquor at all. The gynecologist phoned me and thanks me for the proper advice. So, to break the loop of the wrong dates, incorrect growth assessment, and fetal death, the take-home message comes: Assign EDD preferably between 8 to 14 weeks correctly. Always ask previous report. Don't change EDD in subsequent visits. Rather see for any growth discrepancy. Use Samrakshan protocol, first trimester and third trimester Doppler, and help in reducing the perinatal complications, which is our prime duty to help our mother and unborn children. And very, very important, as per recent ISO guideline, you should use the word as AGA, SGA, LGA, or FGR with growth assessment in the percentile rather than IGR, symmetrical or asymmetrical. They don't serve any purpose. Thank you very much for kind listening, and these are the few references from the journals. Thanks a lot.
Thank you. Thank you, sir. Thank you, Lalit sir, for that wonderful lecture. There are a few questions, but we will take up the questions at the end of after the Dr. Bavaharan session.
Okay.
Yeah, we'll please remain on please be there to answer those questions. There are a few questions, but now we will move on to the next session. That is a very interesting topic. That is the pathophysiology of fetal growth restriction, the how and why of a growth restricted fetus. This is a topic that has to be heard from Dr. Bavaharan, because the way he convincingly explains the logical sequences of what is happening within the uterine environment and within the fetus as an adaptive mechanism and what goes wrong is something that you have to hear from Bavaharan. I've heard it many times during the Samrakshan CMEs, and he has convincingly explained the logic behind it and why there is a need for Dopplers, integrate Dopplers, and to monitor these pregnancies. And this by itself, this basic understanding itself can change our perceptions about fetal growth restrictions and the way we approach them. And then all these things can make a significant difference in the perinatal outcomes in this country. And about the speaker, our Dr. Bavaharan Rajalingam, I've already mentioned, is well known as a mesmerizing speaker in the IRIA circles. And he is not only, his expertise is not limited only to fetal radiology and fetal-maternal medicine. He is a fetal interventional radiologist. And in fact, there is a sign in all modalities, he is very good. And in many systems, especially there is a sign by his name, Ram Haran sign, that is a juvenile nasopharyngeal angiofibroma. And that is a well-documented sign. And with this introduction, may I introduce the National Academic Lead of Samrakshan, Dr. Bavaharan, to speak on understanding the how and why of fetal growth, of growth-restricted fetus. Over to you, Dr. Bavaharan.
Thank you, sir. Thank you for the kind words.
Dr. Lalit Sharma, sir, can you please stop sharing your screen?
Screen has to be shown. Sir,
Lalit,
the
sir?
screen. Lalit, sir, you have to
Stop sharing, sir, please.
Screen. Okay.
Thank you, sir. It's done. Thank you.
So, good evening, one and all. Welcome to the web series of Samrakshan. So, as you all know, we started the Samrakshan, as Dr. Rijo sir told, way past in last year, 2019. We had the focus especially on changing the approach, as already been discussed over a lot of times, how we can change the fortune of the newly born babies if we actually do a proper monitoring of these fetuses. Again, when all this started way back in about 20-25 years ago, there were so many scans being done on a patient, which was not having any logic behind why so much of scans to be done and what needs to be done and all those stuffs. But after a period of time, there was a very particular protocol. We now actually, by the FMF Foundation and by our expertise, we have slowly come down to a conclusion that, well, is very, very important. And the dating scan is very important. As Dr. Lalit sir already has pointed out, do not change the EDD which has been assigned before. Now, every scan and every scan report should not have a different EDD. That confuses the patient, that confuses the consultant, and also for example, if you are not available, another person is doing a scan at, let's say, about 30 to 33 weeks, it might entirely confuse him which dates to take. So do not change the dates. So that is what is very, very important. Now, coming on to fetal hypoxemia, so much being talked about FGRs. Now, fetal hypoxemia is actually very well monitored by Doppler. That we have to understand. So the emphasis of Samrakshan is to make sure that we do a proper Doppler evaluation, starting from the first trimester, which was explained beautifully in the previous webinar. And now in the third trimester, we need to have a complete follow-up. Genuinely, we'll have to do it precisely. That's very important. Precise Doppler is very important. As a radiologist, we should not only do and report the values, we should interpret the Dopplers. Now, we are the ones who does the scan, who does the Doppler. Just one button, we'll have to do a Dopplers. We don't stop there. We interpret the Dopplers. That is very important. Now, giving the diagnosis is not difficult, but telling what to be done next is what is mandatory. Now, this is very important. What is our role is to identify small fetuses. We'll have to differentiate it between fetal growth restriction and the small for gestation age. That's very, very important. Now, when we diagnose it to be a FGR, then it is important for us to make sure that is it early or late. So what is this early and late? Why it is important? See, any early FGR is FGR which happens before 32 weeks. Late FGR is the one which happens after 32 weeks. That's a basic classification. Now, coming on to SGA and FGR, the weight less than 10th percentile or abdominal circumference less than 10th percentile is classified as SGA. When you have a Doppler abnormality associated with it, it is FGR. So when the fetal weight is less than 10 centile or abdominal circumference is less than 10 centile, without Doppler abnormality, it is SGA. With Doppler abnormality, it is FGR. But when the fetal weight is less than 3rd percentile or abdominal circumference is less than 3rd percentile, with or without Doppler changes, you have this to be a FGR. Now it directly classifies as FGR. That is very important. So knowing all this, we need to do a stage-based management protocol. That is very important. So we need to step into the shoes of clinical radiologist rather than just a scan doing radiologist. So there are two differences. We need to get into a clinical frame of mind. So before getting into the pathophysiology proper, this is the fetal circulation that we all know of. And the important point is the umbilical arteries represent placenta, the umbilical veins represent the fetus. So that is the basic difference that we'll have to know. The umbilical artery finally takes the deoxygenated blood from the fetus and goes to the placenta, where the placenta acts as an oxygenating membrane. And from there, the oxygenated blood is taken by the umbilical vein and it is taken into the fetus, and through the ductus venosus, it enters into the intrahepatic portion of IVC, from where it enters into the right atrium. So this is very important. Now, this umbilical vein goes and drains into the fetus. So this represents the destination. So that is, the fetus is represented by the umbilical vein, whereas the umbilical artery goes and drains itself to the placenta. So the placenta resistance is actually represented by the umbilical artery. So it is the placenta. For example, the placenta has to be at least 50% damaged. A placenta has to be 50% damaged for an umbilical artery to become abnormal. We need to note that. So in the first trimester, let's go back to the first trimester, recollect our knowledge. We have been talking about the uterine artery Dopplers. In the uterine artery Dopplers, the uterine artery also goes and finishes through the spiral arterioles into the placenta. So the uterine artery also represents the placenta. So the first trimester uterine artery increased resistance means the placenta is likely to be damaged, or there is a disease process underlying the placenta which can inhibit the enough flow of blood into the placenta, so that from the placenta blood oxygen on the nutrients cannot be properly transmitted to the fetus. So that is what we are identifying in the first trimester. So in the first trimester, when we do a uterine artery Doppler, we are indirectly assessing the placenta. That is why when we say the placenta is abnormal, if the uterine artery percentile index is more than 95, then we start the patient on 150 milligram of aspirin. So we need to understand this. So placenta is the watershed between the mother and the fetus. So the maternal side of placenta is represented by the uterine artery, which you actually evaluate in the first trimester. Whereas in the late second and third trimester, you assess the umbilical artery so that you know how much, whether the placenta is damaged or not. If it is damaged, how much? Now, with this umbilical artery alone, we cannot take a decision, because umbilical artery does not represent the fetus. Umbilical artery represents the placenta. So we cannot take any decision based on the umbilical artery or the uterine artery alone. We need to come to the fetus. So we need to know how the fetus responds to all this hypoxia. For example, when the placenta is damaged, the deoxygenated blood going from the baby through the uterine artery into the placenta actually cannot be properly. For example, let's say 100 ml of deoxygenated blood goes to the placenta, and the 100 ml cannot be filtered and come back oxygenated and get back to the umbilical vein, because the placenta is 50% damaged. So what happens? This deoxygenated blood stays back within the fetus. So the fetus become a bit hypoxemic because of circulating deoxyhemoglobin. So at this stage, the baby adapts itself. The baby says, yes, I know I'm a bit diseased. I'm not having enough oxygen in my blood. I need to adapt. That adaptation, baby tries to have it for some time. When this adaptation becomes decompensated, the baby starts to deteriorate. That is the stage we need to catch and deliver the baby. If that happens, what happens when deoxygenated blood is more in the blood? When deoxygenated blood is more in the fetus, what happens? There is increased carbon dioxide. It means the baby is going in for acidemia. That is what we are calling. This acidemia is very toxic to the fetus, because that may damage the fetus and the brain. The important point of doing all this Dopplers is not only to get a healthy baby, but neurologically healthy baby. It should be neurologically intact, and the baby should be absolutely fine when you have to deliver. So we'll see how these things happen, how this thing roll around. There are 3 important steps to fetal oxygenation. Oxygen should be transferred across the placenta. There should be binding of oxygen to the fetal hemoglobin, and the oxygen should be consumed for growth and metabolism. So this is where we are talking. If the placenta is damaged, let's say the placenta is damaged, what happens? The oxygen transfer across the placenta is completely affected. So what happens? The enough oxygenated blood will not enter into the fetus. Now, when the baby consumes the oxygen, the final product is carbon dioxide and water. So what happens when the carbon dioxide is more in the fetus, when there is no enough oxygenation happening at the level of placenta, the baby goes in for hypoxemia and slowly proceeds itself to acidemia. Now, this acidemia is represented by certain Doppler changes. We have Doppler changes. We'll see how this happens. There are 3 types of fetal hypoxia, if you have to note. One is hypoxemic hypoxia, which is due to placental cause. And all this leads to fetal tissue hypoxia, that is ischemia. So this ischemia can happen to all the organs in the body. For example, a necrotizing enterocolitis. When there is not enough oxygen in the blood, the baby tends to adapt itself by regulating the blood supply. So it decreases the blood to the gut. That causes increased chance of necrotizing enterocolitis in the newborn period. And the other type of hypoxia is anemic hypoxia, where the arterial blood oxygen content is low. Now, this can happen in hypoxia, like due to placental disease or due to breakdown of fetal RBCs. That's what happened in a isoimmunized pregnancy. For example, an RH negative mother having an RH positive baby for the first, and the second also is RH positive, they can be sensitized and that can attack the fetal RBCs. So fetal RBCs actually can disintegrate, and this fetal RBCs will not be able to bind to the oxygen which is provided by the placenta. So they go in for an anemic hypoxia. So this is the basic thing we'll have to understand: the fetal oxygenation, the fetal hypoxic mechanisms. So as we told, there are two different entities. We have small for gestation and FGR. So FGR represents uteroplacental insufficiency, whereas SGA does not have significant pathological problem. When you have, let's say, you have a symmetrically short baby. Let's say you have a baby, by gestation is 30 weeks, but when you do a scan, it's coming somewhere around, let's say, 28 weeks. So you see the mother is also short, father is also short, and there is no Doppler abnormality for this fetus. Consider this as SGA because this is not a pathological variant. So you need to carefully monitor these fetuses also, right? So small for gestation fetus, small fetuses are 10th gestation. So that is important. SGA or IUGR is less than 10 centile, whereas IUGR, the Doppler has abnormal, whereas in SGA, it is constitutional and has a very normal perinatal outcome, no chance of intrauterine fetal demise, and no signs of adaptation. So the placental circulation or the fetal adaptation does not show any change in SGA, whereas in IUGR, there is a difference in Doppler. So these two have completely a different mechanism as the management part and the Doppler part is concerned. Now, we have decided, okay, less than 10th percentile, maybe that is abdominal circumference or fetal weight, less than 10th percentile, maybe an SGA or an FGR. If it is associated with Doppler abnormality, it is FGR. We have to be very clear about that. But when the estimated fetal weight is less than third percentile, irrespective of the CPR, that is the cerebroplacental ratio and the uterine artery Dopplers, this is a SGR. So, but why should we consider 10th percentile as cutoff then? Now we know only when less than third percentile, we consider it to be a FGR, right? Without any Doppler abnormalities. But why is that 10th percentile cutoff? See, you have the 10th percentile cutoff because when you catch the fetus at 10th percentile, it means you still have time for the baby to proceed to third percentile slowly with proper monitoring so that you don't lose the baby. Let's say you catch the baby only at the third percentile, then that deterioration is going to be very quicker and you have very short time for the baby to survive. So you have the 10th percentile. So you follow up slowly, monitor slowly, and give adequate precautions so that slowly you can proceed so that you have a neurologically healthy baby. This is very important. Every one of us should practice it. And this is growth charts. So growth charts are very, very, very essential. This indicates the velocity of the growth. See, this is important. The pattern. So this is, let's say, this is the 5th centile. This is the 50th centile. This is the 95th centile. The growth should always be parallel and should not cut across and go beyond. So you could see here, the growth is good. Growth is cutting off. You could see the abdominal circumference, which is very low. So if you take only this, you may say, okay, probably I'm having a low birth weight baby. Is it normal or not? When you know the previous two values, you can plot that and know this baby is not having a good growth velocity. So this is called the growth velocity. The pattern of velocity is very, very important. Okay, now we know what is SGA. We have decided what is the definition of SGA and FGR. You know why is 10th percentile? Why is the third percentile? Okay, now after knowing this, we need to know that SGA can be constitutionally small. When there is placental pathology, we have an SGR in concern. So when you constitutionally small, normal placenta, normal outcome, no Doppler changes, this is SGA. When you have a placental insufficiency, abnormal Dopplers, abnormal growth profile, then this is FGR. The three three important points to be noted. Now, FGR can be less than third percentile abdominal circumference or estimated fetal weight directly classifies as FGR, whether Doppler is abnormal or not. Whereas less than 10th percentile, between the third and the 10th percentile, with Doppler abnormalities, you classify again that as FGR. Now, the classification is early and late, where early is less than 32 weeks and late is more than 32 weeks. Okay, what does the growth charts tell? The growth charts tell you the growth velocity, how the baby grows. For example, when you have a scan done 2 weeks before and you do a scan now, then you will know within this 2 weeks whether the interval growth is normal or not by plotting this growth chart. So that classifies, gives you the classification. With the growth velocity, you don't take any decision. And there was a question last time, I'm asking that if there's going to be a 2-week lag, let's say a 30-week scan I'm doing and I'm having a baby with 28 weeks, there's a 2-week lag. Do I classify that as FGR? The point is always ask for the previous records. If there is going to be a 2-week lag, even in the first trimester, this is absolutely normal. When you have everything normal till the 5th month, that is the anomaly scan, now you have a 2-week discrepancy, apply the percentile chart. Still you don't classify, you apply the percentile chart. If the percentile chart falls below the 10th percentile, you classify that as SG or FGR. What does the Dopplers tell you? The Dopplers tell you the hemodynamic status of the placenta and the fetus. Again, the umbilical, again I'm repeating, umbilical artery represents the placenta, the ductus venosus, the aortic isthmus, middle cerebral artery, and the umbilical vein represents the fetus. Again, in the first trimester and the third trimester, we do uterine artery Dopplers. So uterine artery Dopplers again represents the placenta and not the maternal state, not the fetal state. So decision making is done by using a Dopplers. So that is very, very important. So SGA fetuses are associated virtually normal perinatal outcome as already discussed. No Doppler abnormalities. No, if there's no Doppler abnormalities means there is no sign of fetal adaptation. So that is important. Next, we have already classified FGR into early and late. Why this 32 weeks? Why do we should have a cutoff of 32 weeks? See what happens till first 16 weeks, there is mostly cellular hyperplasia in cases of fetuses. That it divides, it only divides. Whereas 16 to 32 weeks, the fetus goes on for hyperplasia and hypertrophy. The cell divides and also enlarges in size. Whereas after 32 weeks, it is predominantly hypertrophy. That is, already the division is over and the fetus cell starts to hypertrophy. So this is important because these are two different entities. There are two different entities. One is hyperplasia and hypertrophy less than 32 weeks, whereas more than 32 weeks, it is only hypertrophy. So why this is important? We have to note why this is important. So early growth restriction always have symmetrical effect, whereas in more than 32 weeks, it will have a asymmetrical effect. That is one thing. The other important thing is that less than 32 weeks means the fetus has a very good time to adapt. See, let's say two different examples here. Let's say one baby, one fellow who is having only, let's say 2 meals in a day, because already his placenta is damaged, he doesn't have enough income. So let's say the income is like placenta, where he doesn't have enough money. So he takes only 2 meals a day. Let's say another example where he is a very rich child having at least some 4 meals a day with all desserts and everything. There are two different. So one is less than 32 weeks, the other is more than 32 weeks. So this early fetus, early FGRs, they have like poor babies who is already fed only 2 times a day. Now suddenly you tell, I'll give you only 1 time feed only a day. The baby still adapts itself. He knows I am poor. My environment is very poor and my fetal circulation is very poor. I still, till now I had 2 meals. Now I'll have only 1 meal. So the baby will try to adapt. So the baby adapts itself very well and the baby has enough time to adapt, as well as it's mentally very prepared. I know I'm sick, I'll have to adapt myself. Whereas the other fetus, let's say more than 32 weeks, it means that particular fetus is like a rich child who is already having four times with all the desserts. Suddenly you say, I'll give you only 3 meals. The baby will not be able to tolerate that, because we'll say, no, I'm having till now I've been having 4 to 6 meals a day, and today I don't have one meal, then it's very difficult for me to live. So how will I do? The baby goes in for a nervous breakdown. The baby's adaptability is very, very poor. The deterioration is very, very fast. Whereas less than 32 weeks, the baby adaptation is very good, the deterioration is slow, and the baby can be monitored well. Whereas after 32 weeks, it is very, very fast. Everything will deteriorate very quickly. So you need to understand this two different pathological entities with this example. So that is why we have, see, in less than 32 weeks, the placental damage is very severe. So the baby knows, yes, I'm having a bad placenta, I will adapt myself as much as I can. Whereas after 32 weeks means, that is late onset FGR fetuses are like this rich fetuses who have been having a good placenta, knowing that, but suddenly some minimal part, less than 30% of placenta is only damaged. Still, it has 70% placenta. But according to the velocity of this fetus growth, the baby will not be able to adapt itself, because how will I manage 70% of placenta? That's already 30% is gone. I've been having 100%. Now I don't have 100%. See, that is what the difference. The baby deteriorates fast. So you need to understand these two examples, early and late. So as you all know, the problem is in management. The placental disease is very high in early IUGR. There is hypoxia, but the baby adapts beautifully to it. Beautifully. The baby adapts very, very beautifully to IUGR. Natural history still has a high mortality and morbidity, but if properly managed, you can deliver a very healthy baby. Whereas late onset IUGR, the problem itself is diagnosis. As I told you, the placenta has to be damaged 50% for the umbilical artery to be abnormal. Whereas in late onset IUGR, the placental disease is less. You could see the placental disease is less. So what happens? The uterine artery and the umbilical artery may not show abnormality till the baby suffers the IUGR. That is why picking up these things are very, very important. So the umbilical artery and the uterine arteries may be normal for late onset IUGRs. These are two different entities. So how do I diagnose late onset IUGRs? By means of CPRs, that is cerebro-placental ratio. So that is important. So hypoxia is low, and low tolerance, no natural history, low mortality, but has a poor long-term outcome. So now you understood what is basic classification and early onset, late onset, FGR, and how to differentiate SG and FGR. So these things next are important. The Doppler studies, the uteroplacental circulation, including the umbilical artery and the uterine artery. The fetal arterial Doppler is important. Fetal venous Doppler is important. We'll see how these things are important. So uteroplacental circulation has already been discussed. We know when the placenta does not have enough villi for a good transfer of blood, then what happens? There is impaired maternal and fetal transfer, which already we have discussed. We have discussed that when placenta is already damaged, uterine artery blood flow cannot completely enter into the placenta, because placenta says, I can accept only 100 ml today, I'm already damaged, you send me 100 ml. So what happens? The resistance in the uterine artery side increases. The resistance increases, and over a period of time there can be reversal. That means the placenta is no more possible for it to adapt or take more blood into the placenta itself. So similar thing you remember for uterine artery and umbilical artery also. So what happens in a normal placenta? When the glucose is normal, intervillous blood flow is normal, the fetus has normal glucose. So when the fetus has normal glucose, it actually stimulates production of insulin from the placenta, from the pancreas of the fetus, which acts as a growth factor, which has a good glycogen storage, good somatic growth, and good fat deposition. Now this fat deposition, as you all know, is very important, because this fat deposition is a brown fat deposition, which actually gives warmth to the fetus in the neonatal period. What happens in a diabetic mother? In a diabetic mother, the glucose is very high. The intravenous blood flow is normal, but the entire glucose is transferred to the fetus. So insulin is very high. So insulin is very high. It means the baby feels I have more growth hormone. So it has increased somatic growth. Baby goes in for macrosomia. It can go in for high glycogen storage. That's why in the liver, so that the abdominal circumference increases and more fat deposition. And what happens when there is more glycogen storage and more fat deposition? That can lead to diabetic acidemia also in the fetus. That is a different set of pathology later. So what happens in preeclamptic fetus? As we all know, the placenta does not have enough space. The placenta in the spiral arteries does not have enough space. In simple words, though the placenta is formed, the internal vascularity is very poor. So the placenta does not have enough bags of space for it to accept more blood. That's all. It's as simple as that. So what happens? The placenta is diseased. Mother has a normal glucose. Intravenous blood flow is low. So what happens? The glucose transferred to the fetus is very low. Still the glucose is normal in the mother. The placenta is diseased, but the glucose across the fetus is less. So insulin is less. So that leads to decreased glycogen storage, decreased somatic growth, that is IUGR, and decreased fat deposition. That is why these fetuses grow in for hypothermia after delivery. You need to give warmth to the fetus. You give heat to the fetus by lights. So that is because the fat is low, decreased glycogen storage in the liver. That is the reason why the abdominal circumference of the fetus goes in for small things in the first place. So why abdominal circumference goes small? Because the liver does not have enough glycogen storage. That's the first parameter that is to be affected. Now you should know why AC is first affected. That is why we say classify FGR based on estimated fetal weight or abdominal circumference. So these are two different placentas, you know. So what happens in the uterine artery? As you all know, the uterine artery has to be evaluated in this way at the level of iliac vessel crossing or at the level of cervicobiometrial junction below. So you could see here, keep the vessel, keep the box as narrow as possible. This is very important. See, in doing a Doppler, you don't widen the box. You always try to narrow the box. The first point, when you get the uterine artery, it is important to zoom the picture. It is important to zoom the picture, put the Doppler, zoom the picture, put the color box. You can narrow the color box and you can elongate the color box. That is from top to bottom, you can elongate because your frame rate will not fall. Whereas when you widen the box, your frame rate will fall. You can see that when you widen the box, the frame rate falls. Always keep the color box as narrow as possible and put the sample gate here. So once you put the sample gate, you have the systolic and the diastolic component. So this is what is important. A good diastolic component means the spiral arterioles is very good. There is no recoiling and the vessel has enough space. There is no elastic recoiling. Now, the point on notch, we don't consider notch because when you take a PI, pulsatility index. So when you take the pulsatility index, the notch is also considered. So you don't report notch. So notch cannot be reported, need not be reported. If you report notch, then the consultant and the patient may become panicked. So do not report the notch. Notch need not be reported. Let's be very clear about it. So this is how we have to evaluate it. So normal uterine artery Doppler, decreased diastolic flow and reversal of diastolic flow. Now, there are three parameters that you have in your machine. You have the resistive index, you have the systolic but the diastolic ratio, and you have the pulsatility index. Now, which three of this to take? For all the necessary things, keep your pulsatility index. Because resistive index can be maximum only 1, and pulsatility index can be variable and it can have larger values. A difference may be there, and you always keep pulsatility index as your value. Next comes the umbilical artery. See, the umbilical artery, as I told you, it reflects the placental resistance, and by 15 weeks, diastolic flow can be identified. So for the umbilical artery to be abnormal, you need to have 50% of the placenta to be damaged. So when there is further damage and further resistance increases, there is absent or reversal of diastolic flow. So the umbilical artery, again, you take the pulsatility index. So a normal umbilical artery, decreased diastolic flow, This is the absent diastolic flow and reversal of diastolic flow. Again, taking the umbilical artery is very important. Not too close to the placenta, not too close to the fetus. Take the mid section of the placenta, put the color, zoom it as much as possible, keep the color box narrow and apply the sample gate of 2 millimeter. So you'll have a good systole and a diastolic component. So this is an example of decreased diastolic flow, and this is an example of reversal of diastolic flow in the umbilical arteries. So as I told you, umbilical artery is not a standalone for deciding the delivery if the baby is an FGR. Remember that. So umbilical artery cannot be a standalone criteria. Okay. Now we have the placenta, which is already damaged. The baby senses it. I'm not having enough oxygenation. Already more than 50% of the placenta is damaged. The baby now has to adapt itself. If the baby doesn't adapt itself, it's going to succumb in dry. So the baby has to increase the blood flow to the adrenals, the heart, the brain, which is called the brain sparing effect, whereas it decreases to the gut, kidney, and the lungs. So the adrenal is very important because adrenal has to provide enough steroids to the baby for it to live in those toxic environment. Now the baby has to fight it as adrenaline pumps in us in the adult when you feel a fear. Similarly, the fear creeps in the fetus, and that leads to increase in the flow to the adrenals. It needs to have a good flow to the myocardium. If there is decreased flow to the myocardium, then the baby may go in for myocardial cardiomyopathies later on. That is also being documented. And if there is no enough blood flow to the brain, the baby can suffer a neurological insult. So these are the things the baby adapts itself, whereas with the gut, it decreases blood flow. So that is the reason why there is increased chance of necrotizing enterocolitis later in the gestation, decreased flow to the kidneys. So that is the reason why there is oliguria and there is oligoamnios in cases of early onset IUGRs, decreased flow to the lung. The pulmonary artery circulation constricts so that there is decreased flow to the lung. That is the reason why the baby goes in for respiratory problems, postnatal delivery, and lung immaturity that can be due to decreased flow to the lung in the prenatal period. Again, coming on to this, again, you should know the umbilical artery again represents the placenta, the umbilical vein, and the other circulation only represents the fetus. So what happens to the middle cerebral artery now? The fetal brain senses it doesn't have enough blood flow, doesn't have enough oxygen. So the fetus senses I need more blood to the brain. So I'm going to dilate the vessels. So what happens? The more blood is pushed into the fetal brain. So that is the reason the baby can sustain the oxygenation to the brain so that the brain doesn't decrease in damage. So what happens? There's a chemical receptor mediated vasodilatation. So there's a chemical receptor mediated vasodilatation. The fetal brain always has a high resistance flow, you know that. Whereas adult ICS, when you do a Doppler in the carotid arteries, internal carotid arteries, you know we have a low resistance. Whereas in fetus, you have a high resistance flow pattern. You know that is because the fetus brain is trying still to neurulate. The myelination is still happening, and there is more water across the circulation. That is, the neural elements are covered with vascular bundles, and these have more of water content, and this has to have a pressure. This exerts a pressure on the cerebral vessels. So that leads to increased resistance in the normal fetal life. Whereas when it happens, when this hypoxia happens, the fetal brain senses, I don't have enough oxygen, so I need to increase my diastolic flow component. So what happens? The pulsatility index is defined by, you all know that, the pulsatility index. So the pulsatility index, it's always defined by the MCA, that is the pitch systolic velocity by the diastolic velocity into it. So the more the diastolic component, what happens? The PI falls. There is low resistance. So the brain tries to make itself low resistant so that it receives more blood supply. So what happens when it starts to receive more blood supply? The diastolic component has to increase. So remember, in cases of hypoxia, the brain adapts, fetal brain adapts by increasing the blood supply. That is the diastolic component. That is why the PI falls. The PI falls. Whereas in cases of fetal anemia due to isoimmunization, if you take where there is cells, alloimmune cells, which actually attack the fetal RBCs, thereby breaking the RBCs. So enough oxygen is not there. The baby already has more blood, which is watery blood. So in that case, the baby stresses by contracting the vessels and getting more of systolic component. That is why you measure the peak systolic velocity in cases of fetal anemia due to isoimmunization. Whereas in cases of fetal hypoxemia, the fetal brain responds by increasing the diastolic component, thereby decreasing the PI. So we were talking about the CPRs, that is the cerebroplacental ratios, which is MCA pulsatility index divided by the umbilical artery pulsatility index. So that is the cerebroplacental ratio. Cerebro is because you take the PI of the brain, placenta by means of umbilical artery PI. So you divide these both and you get the cerebroplacental ratio. So as the disease progresses and we don't address it properly, what happens? There is increased edema, thereby decreasing the flow, going in for decompensation. That can also happen. So this is where you take the axial sections at the level of the you take the thalami and you put a Doppler there, narrow the box again, and you apply the sample gate close to the proximal part of the MCA so that you get a good flow. This is how a normal MCA flow looks like: a high resistance, good peak velocity, whereas decreased lesser diastolic velocity with a high PI. Whereas this is the case where there is a normal PSV, whereas increased diastolic component, thereby decreasing the pulsatility index. So the PI decreases. So this is important. Where to measure? Close to the internal carotid artery. This is where it has to be measured. This is the portion that has to be measured, right? So putting the color box is again important. Now there'll be a lot of questions. Now, do I have to change the angle? Do I have to keep it at 30 degrees? It is not necessary, because angle does not change the indices. The pulsatility index, the S/D ratio, and your resistive index does not change by changing the angle. It's only when you have to measure the peak systolic velocity, you need to change. When you measure the peak systolic velocity, you need to change the angle. That happens when you want to measure in fetal anemia, not in hypoxia. Again, you could see here, this is how a normal Doppler is to be evaluated. So put the sample gate properly within it and zoom it properly. Zooming is very important, and you measure it very properly. You have the Vmax, you have the velocity, you have the pulsatility index. This is important. Now, CPR is very standard. Now, the next question, does CPR change in every gestation? No. So the CPR is a ratio. So the ratio should not be less than 5th percentile. So this is very important. The ratio should not be less than 5th percentile, because MCA PI, so this is again important. So you always measure MCA PI by umbilical artery PI. So when you have, let's say we were talking about the late onset FGRs where the umbilical artery may be normal. So what changes? The MCA changes, because the baby knows it is unable to have enough blood. As I told you, in late onset FGRs, that is after 32 weeks, the baby still has a good amount of placenta left, but the baby feels, no, I've been getting 4 liters of oxygen a day. Now I'm getting only 3.5 liters. I need to adapt. So the baby umbilical artery doesn't change. Baby changes the middle cerebral artery. So that the middle cerebral artery PI decreases. So the umbilical artery PI remains the same. So that's where the changes occurs. So you diagnose late onset FGRs based on CPRs, cerebroplacental ratio. Again, to recollect, estimated fetal weight of less than 3rd percentile directly classifies as FGR, irrespective of CPR, irrespective of uterine artery or umbilical artery indices. When you have estimated fetal weight or abdominal circumference less than 3rd percentile, you have an FGR case at hand. What have we learned so far? A definition of FGR: less than 3rd centile, uterine artery more than 95th centile, CPR less than 5th centile. All this classifies as FGRs. Now, this uterine artery PI of more than 95th centile. See, the point is, when you have an uterine artery PI more than 95th centile, whether it is in the first trimester, whether it is in the second trimester, whether in the third trimester, it is abnormal. The value changes, but the centile is same. When you have an uterine artery PI of more than 95th percentile at any gestation is abnormal. It should always be an average of uterine artery PI. Remember that. Remember that when you take an uterine artery Doppler, you should always take both the uterine arteries, right uterine artery and left uterine artery. That is important. Now, what is the value? In the first trimester, the maximum you can have PI, the maximum average value of right plus left uterine artery by 2 cannot be more than 2.5. In the second trimester, it cannot be more than 1.75. In the third trimester, it cannot be more than 1. So 2.5 in the first trimester, 1.75 in the second trimester, 1 in the third trimester. Let's say 0.75 decrease in every gestation. This is a approximate criteria. Uterine artery Doppler centiles you have online. You can just download it and keep it, or your software is there. It can actually evaluate. Now all the machines, latest machines are equipped with this centile measurements, do it. But when you have uterine artery PI of more than 95th percentile at any gestation is abnormal. Now, you know the classification, we have classified this as FGR. We know that we have an FGR baby at hand. So how does we evaluate? Next is important is deadening thoracic aorta. See, what the baby does is, the baby tries to centralize the flow. Baby does not give enough flow to the peripheries. The baby tries to decrease the flow to the peripheries, like the arms and the limbs. So what happens? The baby alpha receptor constricts the peripheral vessels. There is a adrenergic stimulation. So there is a peripheral vasoconstriction that happens. So thereby keeping the blood flow in the center. For example, when you do a Doppler of the deadening thoracic aorta or aortic isthmic level, so what happens? Usually there should be a forward flow of blood. This is because from the isthmus through the subclavian, the arteries has to go to the upper limb, and the isthmus also gives a fair idea of how the blood flow goes to the lower limbs and the gut. Whereas when there is a constriction, when the baby is already having hypoxia and there is constriction of blood flow to the abdomen and the peripheral vessels, the upper limb and lower limb, there is reversal of blood flow in the aortic isthmus. So this happens in the aortic isthmus. There is reversal of flow. Why reversal? Because the baby constricts the peripheral vessels. The baby tries to keep everything central so that the blood flow, enough of oxygenation blood goes to the brain through the carotid arteries. So the baby tries to push more blood through the carotid arteries into the brain. So that's what happens. So if that happens, there is a reversal. So this is where the aorta can be taken. You can also take in the axial section in the case of aortic isthmus, which is very easy. But this sometimes is difficult when you have an oligoamnios or a baby is not having a good position. Now comes our major player, the ductus venosus. I love this vessel, and this is one of the beautiful vessel which is created by the God Almighty, and he has given such a beautiful. For example, he has created a foramen ovale which mixes oxygenated and deoxygenated blood. He also has mixed oxygenated and deoxygenated blood to the ductus arteriosus, and he also has given this connection to us in the intrauterine period. See what happens. This particular vessel, the ductus venosus. See, the ductus venosus takes, as you know, the umbilical artery brings in the oxygenated blood. It tries to take more of oxygenated blood through the ductus venosus into the right atrium. That is important. Now, this has to be placed in such a way. It's a 2 millimeter vessel, as you all know, 2 centimeter curved vessel. Why this is curved? Because it is narrow, curved, because the God has created in such a way so that this vessel takes the flow from the ductus venosus in a high velocity. This takes in a very high velocity. Why this high velocity is important? See, if let's say the ductus venosus, as you all know, is a low velocity blood flow. When that entire slow kind of blood flow enters through the ductus venosus into the right atrium, this may mix more with the deoxygenated blood. So if the blood and oxygenated blood from the ductus venosus and the deoxygenated blood from the SVC, IVC into the RA, everything mixes, what will happen? The foramen ovale will open very slowly, and mixed oxygenation and deoxygenated blood only will go into the left atrium. So through the left ventricle, entire oxygenated blood will not be supplied to the fetus. So it will again have more of deoxygenated blood. It is curved in such a way so that high velocity takes in. This high velocity, what happens is like a ball mechanism. It's very high velocity such that the oxygenated blood hits the roof of the right atrium. By 45 degrees it turns. It just takes another reflection. That way it opens the foramen ovale and the oxygenated blood enters into the left atrium. So if this mechanism is not in place, every baby will be hypoxic. Every baby will be hypoxic. If ductus venosus is not there in place, every baby will be hypoxic. So this is because it has to hit the roof of the right atrium so that 90% of the oxygenated blood is transferred across the foramen ovale into the left atrium, to the left ventricle, and then to the circulation. This is important. This force is the one which keeps the foramen ovale patent. That is why when the ductus venosus closes after delivery, when the baby ductus venosus closes after delivery, so the pressure, the force in which ductus venosus happens closes. At the same time, ductus arteriosus closes. So the pressure is here increasing. So that leads to the flap to go back to its normal position, thereby sealing the foramen ovale. This is all mechanism should be in place. So everything should be in place so that you have a good flow. So how to take the ductus venosus velocity? You can take it in sagittal. That's already been described last time. So in sagittal as well as in axial, you can do sometimes oblique axials. It is important that you take the place where it gets alias. This is the umbilical vein. You trace the umbilical vein as it enters here at the level of IVC, at the level of the liver, it changes the course. So this is important. This kind of a course is very, very important. Sometimes you may see the umbilical vein, the ductus venosus can go directly into the IVC. So in those cases, there is a different else mechanism, but here you will have to see 95 to 99%. You will see this is how it is. So you put it, you have the S, D, and A. Now, we have discussed previously that any vessel you are going to take is actually representing the end point. For example, the umbilical artery, the end point is placenta, so it represents a placenta. The umbilical vein, the end point is fetus, so then it demonstrates only the fetus. Similarly, the ductus venosus goes and ends where? In the right atrium. So what does it represent? The right atrium. So that is important. This atrial contractions, this A wave is important. That is why when you have this A wave is nothing but the S, D, and A, in which the A is important. This is due to atrial contractions. So we have seen in the first trimester, sometimes the ductus venosus reversal. We have heard about ductus venosus reversals like this A wave reversal that we have been talking about. This is because the entire volume, for example, the blood volume in the right atrium is high, so that the blood from the ductus venosus is not able to completely enter into the right atrium. So there is a reversal. Where is the reversal? The contraction, the ventricular and the atrial diastole occurs, whereas the atrial systole doesn't occur. That is, the atrial contraction does not occur because the atrium is already filled too much. It's very tight. So what happens? It is not able to contract properly. So normally when it should contract like this, it contracts only this because the volume is very high. It is very tense. So what happens? The ductus venosus flow also cannot enter the RA. That is by reversal of this A wave. This is what explains why it happens earlier and now it happens. You should understand why the right atrial volume, blood volume is more. This is again because you should know the deoxygenated blood is there in the fetus. The placenta is unable to purify enough blood, but still the placenta is giving deoxygenated blood sometimes in through the umbilical vein also, and already the deoxygenated blood is high. So what happens? The volume is very high. Baby is also trying to keep the blood flow to the central compartment, to the heart, because baby is trying to reverse the blood flow from the peripheries into the brain. So it tries to keep it in the central compartment. So what happens? The central compartment volume is high. The deoxygenation is also high. The acidemia is also high. That means when the acidemia is high, it means the baby is unable to contract. The fetal atrium is unable to contract. That is why reversal of A wave. So fetal acidemia is represented by reversal of A wave. So this point we should not leave, because it means the baby has gone in for a decompensation, and even if we deliver, we are going to have a neurologically compromised baby. Finally, you have the umbilical vein. So again, in ductus venosus, you can take the PI. So ductus venosus PI is important. There are standard charts, but you cannot have an absent A wave. You cannot have a reversal of A wave. That's all. You cannot have an absent A wave. You cannot have reversal of A wave. It means the baby is acidemic. Final vessel is the umbilical vein, where it is a non-pulsatile flow. It indicates severe acidemia. It indicates imminent death. When you have umbilical vein with this kind of pulsatility, you're going to lose the baby in next 3 hours. So what happens? There is decompensation. As you all know, the placenta is getting damaged. More than 50% in early onset FGR. So in early onset FGR, the umbilical artery becomes abnormal. The uterine artery also becomes abnormal. Redistribution occurs. MCA-PI changes. Thereby, how it changes? By increasing the diastole here. So the PI falls. So what happens? The CPR falls. Then what happens? The umbilical artery shows reversal. Then the pulsatility in ductus venosus occurs. Reversal of flow in the aortic isthmus occurs. Pulsatility in DV finally. So this is the order. The umbilical artery abnormal, MCA changes, aortic isthmus changes, ductus venosus changes, and finally the umbilical vein changes. This is how the order occurs. The uterine artery, umbilical artery, number 1. You have the fetal adaptation, MCA, middle cerebral artery. Then comes the aortic isthmus. Then comes your ductus venosus. Then comes your umbilical vein. Now umbilical vein reversal and the A wave reversal cannot be left, because that indicates severe acidemia. So these are the important things. So as already been discussed, so venous distribution, arterial distribution, and decompensation. Now everything we know how this happens. Now let us recap the criteria. So this is the last slide of the day. Let's recap the criteria. So the small fetuses, ultrasound estimated fetal weight of less than 10 centile. You can also take the abdominal circumference, which is less than 10 centile. Now it can be an SGA baby. You can call it FGA. Are we clear with this? You have an estimated fetal weight of less than 10 centile, an abdominal circumference less than 10 centile. You have SGA or FGR. But SGA also always has a near normal perinatal outcome. But FGR always pathological, whether it is early onset or late onset. It is pathological. It has abnormal fetoplacental circulation and a very poor perinatal outcome, and long-term prognosis is also very poor. How do you classify FGR? Early onset FGR is less than 32 weeks. Late onset FGR is more than 32 weeks. So we are clear with this classification now. Early onset FGR has very good fetal adaptation. Remember that. It is immature, it is small, it has very good tolerance to hypoxia. Baby knows it has a very poor placenta. He knows, she knows that is very, very poor. Baby is very poor. He adapts itself. Though there is severe placental disease, but deterioration happens progressively. You need to catch and deliver at a proper time. Whereas late onset FGR is like till 32 weeks, till there is hyperplasia and hypertrophy. The baby has grown pretty well till 32 weeks. If it happens now, when there is minimal decrease in flow, or decrease in blood flow, or decrease in oxygenation, decrease in nutrients happen after 32 weeks, then the baby has very poor adaptation, because till now the baby has grown well. Till now it has not sensed any hypoxia. It has lived in such a cool, cozy environment. Suddenly you are giving a difficult environment. Baby will not be able to tolerate. So it is very mature baby now, but it is very, very poor to tolerate hypoxia. Though the placental disease is very mild, it has very low association with preeclampsia. Remember that. So Early onset FGR always has a high association with preeclampsia, whereas this has low adaptation, low association with preeclampsia. Not all late onset FGR are associated with maternal hypertension. Remember that. Severe smallness. Final criteria is severe smallness, less than third centile, estimated fetal weight or abdominal circumference, even with normal Dopplers. Do we classify that as FGR? Yes, because of abnormal neurological outcome. This is how we classify. So small fetus, the classification is 10th centile, SGA FGR. If it is less than third centile, directly classifies as FGR. So it is pathological, early, late onset, good fetal adaptation, whereas here it has a poor fetal adaptation. So how do we manage and how do we actually plan the delivery? And how do we take this thing? Try to assimilate whatever I've told you today. So that we'll have our next talk on part 2 on how to actually time and deliver this fetus. Let's revise whatever we had it today in the next talk, and we'll try to discuss how are we going to manage, interpret these fetuses. Thank you.
Thank you, Dr. Bavaharan. That was a wonderful lecture. You have a knack of simplifying complicated things, and that is awesome. Before moving into the question answer session, I would like to consolidate some of these questions here. And as Dr. Bavaharan mentioned, this is a mini series on fetal growth restriction. And we will have a session on 9th of May at 7 o'clock with Dr. Gulab Charger giving a talk on how to measure the Doppler vessels and what are the common pitfalls. Subsequently, it will be followed by Dr. Bavaharan with his talk on the criteria, stage-based management and timing of delivery and all those management related stuff. So before that, we have got a few questions lined up here. May I ask the Mindray team that do we have enough time to take care of these questions? Okay, right. So Lalit sir, there is a question that it generally becomes difficult to explain about corrected EDD to old obstetricians. They expect us to provide EDD for every scan. Based on my experience at least in 4 places, how do we tackle this issue? Please advise.
No,
Can you? Yeah.
Once it is assigned, we must not change it.
Right.
That so is the foremost important thing.
Yeah.
We have to assign at the first examination time.
Yeah.
And never change it. Rather see it as a growth discrepancy. That is very important.
Okay.
Because the other people, that is the thing. Wrong dates, incorrect assessment of the growth.
Okay. Thank you, sir. So the point is, in the first trimester scan itself, if you got a date, don't change it. And subsequent scans, you follow that corrected EDD as per the early dating scan.
Yes.
You have to convince your obstetricians and whether they may, what happens in medicine is old time people may have some set ideas. You have to talk to them, convince them. And the importance of it has already been mentioned by Dr. Bavaharan, because if you keep changing on that, the percentile calculation of the estimated fetal weight, the abdominal circumference, and the subsequent Doppler percentiles also can change and can create a hell lot of a confusion, especially in the 3rd trimester. So that is the one question on that. Do we need to do so? And many of the questions that have seen here as because the concept about the fetal growth restriction and the pathophysiology of it is still a little complicated one. The reason for that, I feel, is over a period of time, maybe at least for 10 years, people were giving undue importance only for the umbilical artery. Umbilical artery Doppler findings were considered as a management strategy to take care of, diagnose FGR and to time delivery and all those stuff. But over a period of time, over the last 4 or 5 years, ever since this Greco's team has come out with the Barcelona staging and all, a comprehensive assessment of all the vessels and the subsequent and basic understanding of the pathophysiological mechanism that happens, that has been already described by Bavaharan. That has to sink into our understanding of these things. So because of that, last 15 years, there has been a lot of confusion. People think that umbilical artery is enough and not all vessels are required. And the concept about early and late onset FGR. That's two different entities. However, there is a question. There are a lot of questions on that. If the baby has been having an appropriate for age growth initially in the 32-week scan, and it has gradually progressed to if estimated fetal weight below 10th centile with normal Doppler indices, would we call it as SGA or FGR?
What was the question? Less than 10th or 10th?
The baby has been having appropriate.
No, sir, there's a break in the voice.
If the baby has been having an appropriate for age growth initially in the 32-week scan.
Okay.
So what we normally classify the early and late FGR as the 32 weeks is the criteria, but at 32 week scan it is okay. But gradually the fetal weight is coming less than 10th percentile, but the Doppler indices are normal. So what will you call it, SGA or FGR?
Let's say you're doing a scan at 32 weeks and then you're calling the patient back only at 30, because when everything is normal by 32 weeks, you don't call back the patient another week or two for us to repeat the scan. So let's say the baby is being called for at 36 or 37 weeks, let's say. In that case, already had Dr. Lalit sir has described, there is always a plus or minus week. So there is about a 7% plus or minus changes in the days. Let's say you have it at 10th percentile and you have a Doppler as normal. Let's say you're unfortunately you have scanned the patient at 35 weeks and you feel 32 weeks everything was normal. Now it falls at 10th percentile and everything is normal. There's no harm in calling back the patient after 1 week, putting that as probably we have to follow this baby's up, and next week you just follow this baby. And if Doppler is normal even at 36, 37 weeks, you just have to continue classifying this as SGA babies, not on FGR. See, the SGA babies are like the previous ones. Let's say naturally the baby is smaller without any Doppler indices changes. So that is where. But when you have a 32 weeker, with everything is normal, you don't call back the patient at 33, 34 weeks to do a scan, honestly. When you do have a problem at 32 to 33 weeks only, you call back the patient. That is how it is being followed. But unfortunately, when you do let's say many of the times when we were practicing, you will have a baby at 36 weeks, 38 weeks. When you do a scan with all the parameters, even Hadlock 3 is available. If you do it, it will still be somewhere around 36 weeks. There is always a 1 to 2% discrepancy will be there. Yeah. So don't play that, because see, when everything is normal at that point, when the baby's weight has not fallen below 3rd percentile, do not classify this as pathological. But for all the safer sake, call back the patient at about a week or two and then follow this baby.
Okay. There is a question on, is it possible that a fetus in stage 1 at 30 weeks, will it remain in stage 1 till term? I mean, no progression in Doppler findings.
Very unlikely, because you have classified this as stage 1. Let's say FGR fetal weight of less than third centile, or the Doppler is showing abnormality. So in whatever, the baby has to be followed up in a weekly interval.
Right.
The baby, the only possible wrong thing which we could do here is not confounding with the previous reports. We are not having the previous reports. Suddenly you're seeing a scan at 30 weeks, 32 weeks, and you put the baby as 29 weeks. You don't see the previous reports, or the previous report is not available. In only that case, you can make a mistake of diagnosing this as FGR. But in all this case, even if you're diagnosed as FGR, don't worry, because it is always good to err on the worser side. Always. Fine. Always err on the worser side. Giving the baby as completely normal and suddenly baby deteriorating, you're going to be affected. But always err on the worser side, even if you want to err.
Okay. Thank you, Bhavan. Are stage-based classification criteria same for early as well as for late onset FGR?
Yes. We'll have the staging in the next stage. We have not included the staging here. I've only given the classification and pathophysiology. Next time, next talk, we'll have the staging. How are we going to stage, and then how are you going to plan the patient?
There are a lot of questions regarding the topic that you are going to cover in the next session, that is on the management part. But I will restrict myself to because these questions we will be repeating in the next session. So I'm not going to ask these questions here. Sir, if fetal weight is less than 10 centile with oligohydramnios, can it be classified as SGA or FGR? The Doppler is normal. Is oligohydramnios a classic criteria? That's the question.
Oligo is not a criteria.
No.
Oligo may be due to any reason.
Okay, fine. So can this be possible? Umbilical artery normal, MCA abnormal, and CPR be normal?
How can it be?
Okay.
See, it's like the percentile, right? You have the
Right.
percentile. You have the when one is abnormal, this ratio has to change.
Yes. Okay. So low resistance flow in MCA goes hand in hand with high resistance. The same question. There is a question. This is in latest edition of ROMAC says umbilical artery S/D ratio is more reliable and useful than CPR. Your views, please.
See, you always do a comparison. See, the advantage, see, there are two different thoughts. See, we have been using umbilical artery S/D ratio 3 years before, honestly. So umbilical artery S/D ratio of more than 3, we tell the placenta is having a disease. We are having a FGR. The baby may go in for FGR. So umbilical artery S/D ratio more than 3 was a classification used, honestly. But now you have the two different criteria, early onset and late onset FGRs. In early onset FGRs, you have the umbilical artery abnormality, whereas in late onset FGRs, the umbilical artery may be normal, where only the MCA changes. So the MCA is important. So see, the entire decision of whether to continue this pregnancy or to follow up this pregnancy or to deliver this pregnancy is going to be based on the fetal response. How the fetus responds and how the fetus adapts, not on the umbilical artery. Remember that. The umbilical artery, anything can be. You can take SD ratio, you can take PI, whatever it is. But it's always important that you should know how the baby responds, right? You cannot decide based on, see, already the baby is poor. Doesn't mean the baby will not be educated well. Baby still can be educated well. Baby may be much brilliant than any of us, any of the high society baby. So it doesn't mean the placenta indicates only the poorer state of the fetus, but the fetus can adapt itself, and it can be severe, very, very, very intelligent, and to adapt itself. So that adaptation is what we'll have to consider and give credit to, not on the porosity of the placenta, not on the status of the fetus, not on the status of the placenta. It is the status of the fetus. So it's like, in the lower slum area, when there is one educated people coming on top, like, Dr. Abdul Kalam has been in the lower part of the economic group. You will see his house, very small house, from which he has come up very, very high. It's a big inspiration to all of us. It is similar to that. You cannot say with poor, the placenta is poor, so I will deliver. So umbilical artery, you can take any measurement. You want SDA, PI, whatever you want, you take. But always have the comparison with the fetus. That is why this ratio becomes important. And you should know how the baby responds and comes up. So that's how you have to decide.
Okay. So there are a lot of questions related to the entering the data in the Doppler calculators. I think you can take it in the next session. Or at times we get absent diastole in MCA, possibly due to the angle of intonation, etc. Kindly guide us regarding. I think these are some pitfalls in MCA measurement. Something Gulab Chajar can answer in the next session. Would you like to answer that question? The causes of absent diastole in MCA, can it be a pitfall?
No. Yeah, that's a pitfall. Most of the times, you just keep the probe you give too much pressure to the probe. See, when you have the head and you give too much pressure with the probe on the head, that might cause decrease in the diastolic flow or even reversal of flow. See, let's say when the baby is completely normal, everything seems to be fine. But when you have the absent diastolic or a decreased diastolic or a reversal of flow, remove the pressure, give a minute or two, and then redo the scan by doing a little pressure. You will see the difference. So it's predominantly because of increased pressure of the probe on the head. Don't do that.
Okay, so I think we are exceeding the time. There are a lot of questions that we have, but basically what I can understand is these questions are related. I think has nicely explained the how and why of the growth restricted fetus. A basic understanding into that is primarily required to understand the next session on the criteria-based management of FGR. So I would request all of you, since this talk will be available in YouTube, this talk will be available in YouTube. You'll be able to see it live again and again and understand that process once again, the pathophysiology of FGR. And that will help you understand the next session on 9th, basically on the criteria, on the stage-based management of FGR. So most of these questions are related to that, relatively poor understanding on that pathophysiology. So after 32 weeks, even if there is discrepancy between BPD and AC by more than 2 to 3 weeks, no need to call asymmetric IUGR. So after 32 weeks, even if there is a discrepancy between BPD and AC by more than 2 to 3 weeks, so do we call it as asymmetric IUGR? I think this has already been mentioned, that terminology of asymmetric IUGR is slowly getting out because the terminology is now coming back to FGR, SGA, and depending on the criteria that has already been explained. Sometimes in third trimester, umbilical artery shows normal tracing, but MCA shows low resistance tracing. So a lot of questions on the difficulties that people face on. So maybe this is basically due to the poor understanding about the pathophysiology, or due to the measurements and the pitfalls, that the issues that they come across while they take the Doppler, which is primarily the topic that we are going to deal in on 9th. That is how to measure and what are the common pitfalls in Doppler and the criteria-based, stage-based management of FGR. So I would thank the speakers for a nice talk. Thank you, Lalit sir. That was wonderfully explained. Your point was well taken. The corrected EDD should not be changed. So that is a request. That is a point that is very, very important in your practice. If there is a patient that you're seeing at 32 weeks or so, ask for the previous scan at 8 to 12 weeks where you can get the EDD from that, and that has to be considered as the corrected EDD. Yes. So, and never change, do not keep changing the EDD in every scans, which is a common practice that we come across. But this is time, once you're aware of it, once you know the importance of it, please do not change that. So thank you, the speakers. I've got more questions here, but I think these questions are more related to the stage-based management. Once again, I request each one of you to understand, go through this talk once again, because this will be available on in YouTube live from the Mindray and the Krest channels, and that will help you to understand the next session on 9th very well. So thank you, Dr. Bhavharan. Thank you, Dr. Lalit sir, for these wonderful talks. Thank you, Mindray India, for power. On behalf of Krest Kochi and IRIA Kochi, I thank all the participants who have joined today for attending this wonderful session. Thanks to the Krest Kochi and IRIA Kochi office bearers, Professor Dr. M.R. Balachandran Nair, the President, Secretary Dr. Ramesh Shanai, Dr. Amal Anni, the National Vice President 2019, and Dr. Praveen Nirmalan and the entire team who has been behind organizing this. Thank you very much. But I request once again to join us on 9th, because this is going to be an interesting session. Request everyone to see this these two talks once again in the YouTube, because that will help you understand the next session much more better. Because once I've gone through this question, there are a lot of questions, but all these questions are basically due to, again, I'm emphasizing that it's due to a poor understanding about the how and why of growth restricted fetus. There is a whole lot of hemodynamic sequences that is happening, and Bhavharan has explained them wonderfully, nicely. This is the best explanations I have ever heard on the pathophysiological processes of FGR. So thank you once again. And before we sign off and say good night, wish you all the best and a good night. Thank you.
Good night.
Hi all, this is Armugam again from Mindray team.
Yeah,
great sessions as usual. Mindray sincerely thank the speakers, Dr. Lalit Sharma and Dr. Bhavharan. We also thank Dr. Rijo Matthew for his valuable guidance and support. We thank entire IRA team and Krest Kochi for giving us chance to be a part of this program. Mindray India is proud to be associated with all of you in spreading clinical knowledge throughout India. As Mindray mission says, we wish better healthcare for all. Let's meet again on Saturday, same time, evening 7 o'clock for second part of this FGR series. Thank you all delegates once again. Good night. Jai Hind.
Good night.